Cairo trip. So this was the sort of title of the talk I was asked to give, and I've trimmed it down, but it is a problem. You get somebody who's post-cholecystectomy, you're all pretty comfortable with. You get somebody with pancreatitis, they get a gallbladder with stones. The logical thing to do is send them for a cholecystectomy. It should be fixed, but what happens if they've already had the cholecystectomy? You know, what are you going to do? I wanted to pay tribute to this guy, and we mentioned him already this morning, but Dick Kazarik is one of my mentors, and in my book, probably the greatest current practitioner of ERCP in the world. And here he is. You know, I think they would have done better at Yalta if it had been Dick instead of these other guys. But here he's talking to, I guess, Churchill and Roosevelt. He's being Stalin, I think, in this thing here. But Dick got the Schindler Award at DDW last year, and I think very well deserved. He's a great guy, and I know he supports you and perhaps some others in this room. Pancreatitis, people find scary, and I do too. It's a difficult problem to deal with, and it needs a kind of systematic approach to it. This is actually probably me attacking a sphincter Oddi dysfunction patient. And you need a stout heart, right, to manage pancreatitis. Yeah. Nobody is immune to pancreatitis. There's a funny story, and this John Ashcroft who got pancreatitis, and when he got pancreatitis, the phone started ringing, and I was still at Duke at the time, and the Duke press office wanted me to talk to some reporter, soundbite, and I've been burned so often talking to reporters, my immediate knee-jerk is to say no thank you, because A, they always twist anything you say to what they want, and they don't have the information, and you really shouldn't comment on famous people's diseases if you're not managing them, because you never get the information. But the word in Ashcroft was that he had severe pancreatitis, remember that? And so they all wanted to know what was the implication of this, and I said no several times, and eventually get the head of the press office at Duke saying, you know, Associated Press on here, they really need to talk to, they want an expert, you know, and I told them you don't want to really comment specifically. So I talk about, well, he really has severe pancreatitis, you know, he's not going to be playing golf at the weekend, you know, it's a severe disease, he may not be able to come back. So 3 days later he has a cholecystectomy and he's out the next day, so you know he didn't have severe pancreatitis, and in fact, this guy never saw a gastroenterologist. He was managed by surgeons in some naval hospital. He never had, by anybody's definition, severe pancreatitis. And so I spent the summer in Guantanamo Bay for my comment. No, I didn't, but it just taught me that yet again, you should not comment on anybody's disease. I mean, he had it locked down so tight that they couldn't give out any information about it, so there was all, you know, whisper. But the interesting thing is, if you talk to Associated Press, you're talking to about 500 newspapers worldwide, and I had buddies of mine from South America and Italy and stuff saying, oh, John, I read about you in the paper, I barely agree with you. Oh, God, you know, so don't do it. I bet you didn't know that dachshunds are prone to pancreatitis. I think it's because you dressed them up in this silly Halloween stuff, you know. But when I went to the web looking for this, the first thing that came up was dachshund.org. So this poor Wills has got pancreatitis. So, stuff you know already, 90% at least of cases of acute pancreatitis in this country are caused by gallstones or microlithiasis. And even when it doesn't look like it's gallstones, it is gallstones. And I have a story I like to tell about. I had a pilot came up from Seymour Johnson, and he'd had episodes while he was flying. He was flying an interesting plane. He was flying a DC-3, which were equipped with turbo engines, and as best I could work out, he was dropping DEA agents into Colombian cocoa fields to burn them, you know, and he kept cancelling appointments and would say, I could tell you where I was, and then they'd have to kill you, Dr. Baillie. So obviously he was doing some missions that he couldn't talk about, but he had some episodes of having acute abdominal pain, and he'd get slumped over his controls and, you know, have to make it back, and he'd been worked up and down through the military. And not found anything, but was about to have his his license pulled. And any of you who are a pilot know that you'd rather have the earth open and swallow you and your family up than lose your pilot's license. And so he was sent up for this workup because at some point somebody had found some mild elevation in transaminases during one of these attacks, and he had everything done. He did multiple ultrasounds, CTs, We ended up doing like sphincter manometry and a whole lot of things that were not the routine direction, but everybody was very intent on finding out what was going on with this guy. We gave him a week of pancreatitis after that, which he took like a good soldier. But he kept having these episodes, and he came, we talked to the surgeons and said, should we take his gallbladder out? Empirically, it sounds like he's having attacks of biliary colic, and somewhat unusually, couldn't really find a surgeon who was too interested in taking his gallbladder out. So the guy came to me one day almost in tears. He's a big tough guy that flies DEA agents into South America, and he said, look, can you not persuade one of your buddies to take my gallbladder out because they're going to pull my ticket? So I sent him over to Ted Pappas, and he said, okay, I'll do it. So he calls me from the OR and says, you come and see this. This guy's got 10 stones in his cystic duct. And even going back to the ERCP with the spirally valve, you couldn't see it. And he was just shooting these off one at a time. So if it quacks like a duck, it probably is a duck. And one thing I'll mention as I go along here, a very good way to look for microlithiasis now is endoscopic ultrasound. It's amazing the number of gallbladders that have been pronounced normal by regular ultrasound. And other imaging, you do an EUS and it's junk pattern, 1-2 millimeter fragments of stone. So recurrent pancreatitis in somebody who's post-cholecystectomy usually raises the possibility of retained stones. Now, if that's within months or maybe a year or something, I can buy that. But if it's longer than that, you've got to start thinking that people are making stones de novo, i.e. they're not something left over from the cholecystectomy, and these are called primary stones, and they take years to develop. These are the people who are 5, 10, 20 years post-chole who get stuff. And if you have lithogenic bile, or you're a chronic hemolyzer, you can certainly do this. And this is a gallbladder opened to show stones, and these are the typical stones that cause pancreatitis. Big stones don't cause pancreatitis because they can't get out. So it's tiny junk. They used to call these in Britain mulberry type stones. I've never seen a mulberry, but maybe that's what a mulberry looks like. But little bits of gravel like that, that's a perfect cause of pancreatitis. I don't know why tiny bits of grit and gravel do it. I personally have a lot of difficulty with the concept of cholesterol crystals doing it. We went through this phase where we'd be sucking bile out or duodenal aspirates and looking for crystals and stuff. That's pretty much been shown to be a useless thing to do, and I can go into why that is more later. But I have a hard time thinking that a few little cholesterol crystals going through the sphincter causes pancreatitis, but I could believe that this stuff does. So secondary stones, they're the ones that are usually milked out of the cystic duct by the surgeon when he's doing his thing. Typically manifest within days to weeks or months. So Mrs. Smith has her cholecystectomy. 2 weeks later she's in the ED with an attack of biliary colic or gallstone pancreatitis. A no-brainer. She had a stone that migrated. Certainly an important piece of information is to have the surgical report, and it's useful to know if the patient had an IOC, intraoperative cholangiogram, what did it show, did they instrument the duct, those kind of things. That's very helpful to know. You also want to know, this is a nice euphemism that our surgical colleagues use when they talk about a difficult cholecystectomy. That means they get in there and it was a mess, adhesions everywhere. They usually don't do a complete cholecystectomy. Often what they'll do is they'll chop what they can of the gallbladder out, but they'll leave the gallbladder neck in, Hartmann's pouch, maybe even leave a drain in. You know that if they come out the OR and they've got a JP drain in there, that the surgeon didn't do that for fun, that he left. Usually knows there's a bile fistula there and he's hoping you're going to fix it if this drain doesn't. You also want to know if there are indicators of possible common duct stones, and these are the surrogate ones, the dilated duct, the abnormal LFTs. It's also helpful to know if there's been other imaging. EUS is very good for looking for stones. MRI now, MRCP is very good. I don't like PTC much, but if they had one, that's helpful. And you also want to know if the patient's had a prior biliary sphincterotomy. Now, it used to be said that sphincterotomy would protect you from further problems. Well, it doesn't, and I'm sure we've all seen patients that have had a sphincterotomy and come back with a stone stuck there in the duct and you've no idea why it didn't pass. But just because they've had a prior sphincterotomy doesn't protect them from further stone problems, and of course the danger is if you make a very small sphincterotomy it can stenose. I don't see much of that now. I did 10-15 years ago because people who were not very good at or not very confident at doing sphincterotomy would make a tiny nibble And if you're only going to make a 5 mm nibble, please don't do it, because that, the work from way back in dogs, Steve Silver showed 25 years ago that what happens to a sphincterotomy is that after a year it's half or less the size a certain amount, 50%. So if you've only done 4 or 5 mm and it shrinks to 2 or 3, you may have caused papillary stenosis. So you need to know a little bit about what they've had done before. So this is EUS, and I think EUS is at a stage now where you can see lots of interesting things. I mean, you wouldn't have any difficulty recognizing that as a stone with shadowing on it. So again, if you have EUS in the house, it's helpful. I think this is a kind of fun picture. This is an MR seen in a plane. You don't normally do it. This is a sort of section through the body north to south, and what you're looking at, these are kidneys here, but this is the bile duct end on, and this little eyeball is a stone sitting in the dilated common bile duct here. I used to think that MRI wasn't much good for stones less than 5 mm, but the quality now is good enough to pick up small stuff. So an adequate sphincterotomy should protect against recurrent pancreatitis, but this is not guaranteed. So I get asked a lot, Mrs. Smith's already had an ERCP by somebody else a year or two ago. They've been sphincterotomized, they get problems. Is it worth going back in and looking? Well, it may be. If you get elevations of LFTs associated with attacks of pancreatitis, and there's no other reason for LFTs to be elevated, then it's a surrogate marker. And obviously, if they weigh 300 pounds and they run mildly elevated alk phos and transaminases all the time because of their NASH or whatever, and they don't go back to normal, that doesn't qualify them. And that statement also applies to sphincter of Oddi dysfunction and how the classification is abused. People get sneaked into type 2 because they have abnormal LFTs, but it doesn't count if they never go back to normal. It's good to know, Steve was talking about somebody who's in a million homeopathic remedies, but sometimes things get missed. I had one recently from my new institution of a young woman who was on pancreatitis, and it didn't occur to the person who'd started the 6MP for her Crohn's disease that was probably going to be the cause of it, which was sort of amateur error. But you need to know if they've gone on some new drug or whatever, and one of the things I find it hard to keep up with in my practice is all the new drugs these people go on to. And there's a big range of drugs that can cause pancreatitis, and it's worth reviewing that from time to time. Certainly EUS is less invasive and less morbid than ERCP. It's extremely good for biliary sludge and for stones both in the gallbladder and the bile duct. And as an extra little bonus, you get a look at the pancreas while you're there. So I have an excellent colleague, Girish Mishra at Wake, who we do a lot of tandem procedures. Now he'll start with the EUS and I'll be there with the ERCP if he needs it. Now the downside of doing that is you don't get paid for it. There's this awful bundling of procedures thing that another game that the insurers pay for not giving you money. If you do those two procedures on the same day, they'll only pay for one of them. And we're all trying to work out how we can deal with that, but it makes sense to start sometimes with an EUS, and if they see a stone in there, we can go ahead and...
Use them at 11:30 p.m.
Okay, thanks, I'll do that. The other thing is that's coming up is that, we've all been talking for years about it would be awful nice to have an ERCP scope that had a switch on it that you turn on the radial transducer and you get the EUS view of the bile duct. You're right there, and there was a paper or an editorial in either this month or last month's GIE about that, so that's coming and it makes sense. ERCP does offer the opportunity to do manometry, and I think this pretty much most places only done in specialized centers. What we do know is that if having idiopathic relapsing pancreatitis, you do a biliary manometry and the pressures are elevated, you need to go and check the pancreatic pressure too, because in about 60 to 70% of cases that will be abnormal as well. And that work came out of MUSC. So SOD causing pancreatitis, you may be able to cure that by sphincterotomy. And that's very much a setting where we want to stent the pancreatic duct, because Marty Freeman's data, which every lawyer in the country who does this medical litigation knows, is they now have statistical evidence of what the risk of pancreatitis in various groups is. And if you haven't read Marty Freeman's multi-author paper in the New England Journal about risk factors for sphincterotomy, you ought to go and read it and familiarize yourself with it, because the range went from about 2%, which is the old ladies with the dilated ducts and the big stones, which you can do anything to and they don't get pancreatitis, to the sphincter-eroded dysfunction, it was 43%. And they'll sit in a deposition and they'll add it up. Well, Dr. Baillie, would you agree Dr. Freeman's data from the, start off, would you agree Dr. Baillie, the New England Journal of Medicine is a prestigious journal and you can rely on what's in there. Anybody in a deposition, that's how they do things. First of all, they establish, do you agree that Yamada's textbook is a authoritative thing? Well, if it says in there that X is X, do you agree that, lead you down the slippery slope here? Well, they'll quote Marty Freeman's data to you and say, well, if we add up the risk factors for this patient, do you agree, Dr. Baillie, that this patient has a 37% chance of developing post-ERCP pancreatitis, and don't you agree that standard of care requires that you would consent the patient so that she knows that that's the case? So you need to know those data if you're going to be consenting people. And they suggest that you actually write your own data down on the consent form. So if your perforation rate for colonoscopy is 10%, you're meant to write that on there. Because if they see that and they're still prepared to sign it, well, more fool them, but they've signed and okay, I accept Steve Schutt's got 1/10 chance of blowing a hole in my colon, I'll take that. Because the process of informed consent is the process of sharing risk. The patient is accepting some risk for the procedure. So if you write down there, the game that always used to be played with this bragging rights, some people out there said, my post-ERCP pancreatitis rate is 0.5%. Well, that's a fantasy if you do ERCP. There was all this, how much bigger and better can we get? What they should have done is write on the consent forms, we have 30% chance that you'll be in here at least overnight with pain and stuff, because that was the honest thing. And when it comes to risk management, being honest and being, having that in writing will protect you every time. So again, SOD is kind of specialized, but there is a little group of patients who need this stuff done, and you should send them to a specialist to do it. MRCP, as I said before, is getting better. PTC, I don't like PTC. I think PTC hurts people. It may not be that painful at the time, although a lot of people come back from PTC saying it was the worst thing they ever had done. At Duke, we had to almost have a war with our vascular radiologists to get them to use regional blocks. They go in under ribs where nerves and things are. But they're not sore at the time, they're damn sore afterwards. You get PCA pump them and other things that they're sitting with a catheter hanging out of them. So I tend to reserve percutaneous stuff for really tough situations. And certainly there are cases of anatomical difficulty and stuff that may necessitate it, but I don't think it should be a default. People always ask me about combined procedures, and there was a vogue for that 10 years ago when you get a radiologist in the room and they'd slip a wire down for you and you'd grab it out the papilla. Those procedures had twice the morbidity of normal ERCP. Apart from the fact they were a big performance to do it, radiologists usually did it in an X-ray suite. Usually the patient was lying on their back instead of prone, because that's how radiologists like to do it. Sometimes anesthesia there. It was a big performance, but it was more invasive, and those patients tended not to do well. And some people who were not very good at ERCP use it as an alternative to good technique. And so combined procedures should be used sparingly. This is probably the best picture I can show you of this, and I can't remember where I stole it from, but this is a gallbladder. And you see this thing that looks like a starry night? This is microlithiasis. All these are tiny little dots of light, or little fragments of stone. And this is a bile duct with a tiny, I'm not sure why it's P, because it is the bile duct. This is a tiny stone that's like 2 millimeters and very well seen on EUS here. So I find that a very useful technique. So then now we're very close to the bottom of the barrel. This is when people start sending patients around and start and tell people they're crazy and, I can't figure out why you're having these attacks. So if the bile duct's negative for stones and they don't clearly have sphincter dysfunction, pancreas appears normal, and somewhere along the way you're going to be checking they don't have pancreas divisum, because that is a remediable cause of relapsing pancreatitis. A lot of the time now the EUS people and the MRI, MRCP studies can tell you if they have divisum. But if they have relapsing pancreatitis, so they're having bang and attack, goes away, they're okay, bang and attack, you can help them with a minor papillotomy. if you let that go on to chronic pancreatitis so that they've got chronic pain, the results are much poorer. So we want to get those people early. So what do I do if I get these patients in the door? You know, they've often done the rounds, they've been seen by a number of physicians, they've had things done. Obviously, you don't necessarily want to start at the beginning, but I do like to go back and beat a history out of them again a little bit. I had a guy at Duke who, it was kind of funny, we got him in, he'd been a missionary in Somalia, and he came in with this story of being very sick and this very odd looking CT scan which had just this big mess in the abdomen, and he had raging fevers and he had a big peripheral eosinophilia, so ID were dragged in by the house staff to see him. So they thought that this guy had schistosomiasis, and they got very, very excited by this, and and it looked to me in the CT that this guy just had a bad pancreatitis with maybe a pseudocyst that was forming in the tail and stuff. But this peripheral eosinophilia was a real red herring. So they move him on to another service, and they're doing all of his serology, and none of it's coming back showing schisto at all. And I was just convinced this guy had pancreatitis, and so when I'd go and see him in the room, you know, it was one of these rooms where there's like 20 people camped in their bed, you know, you've been in hospital rooms like that, and eventually I threw them all out one day, found some excuse, you know, they're all sitting with their Bibles open, you know, it was kind of, you know, it was one of those, you know, we had to hold hands and you know, pray for God to help guide Dr. Baillie towards the diagnosis. It was very uncomfortable in a way. You ever had that, when you go to informed consent, you know, we'll all hold hands and, you know. Anyway, I eventually got this guy in his own. I said, you know, this looks awful like to me that this is pancreatitis, and I really need to know, because he'd been asked by other people, and they always said, no, if you drink, and it turned out that life was so hellish for him as an itinerant missionary guy going around Somalia that the only way he could stay sane was they would give him gifts of homemade brew made in, you know, the iron pots and things from villages. So he would go from village to village drunk all day. He would just drink the local brew. And he was drinking a huge amount of this stuff, and he was constantly blitzed. The only way he could keep happy in Somalia, you know. And he had alcohol, you know, some alcohol-related thing, but, you know, I was sworn to, you can't tell my family and this, that. I ended up going to the OR for this. But it was a classic example of how we get led down. You know, the ID guy said, oh, this is Bill schistosomiasis. This is one of my little hobby horses, is hypercalcemia is a rare cause of pancreatitis, and it's almost always due to hyperparathyroidism. As you know, there are a bunch of other causes of hypercalcemia, but for some reason it's hyperparathyroidism that causes pancreatitis. And usually these people with relapsing pancreatitis, the first couple of times they get admitted, somebody checks their calcium, it's normal, then people stop checking it. But if you go back, and you may find it go up, and I had a guy, I have been talking about this for years, and last year I was at a meeting in New York, and a surgical meeting, and this old surgeon came up, told me he's a retired guy, and he said, you know, I heard you give this talk 10 years ago, and you know, I was having attacks about once a year of pancreatitis, and they'd kind of given up on me, and so I went back to my doc and I said, measure my calcium, and it was like 14. And he had his parathyroid adenoma. So that was only one case, it was still worth it. But I suggest to people that if you've got somebody who's come in, every time they come in with a documented attack of pancreatitis, it's an easy thing to do their calcium. It's not worth doing their parathyroid hormone unless the calcium is up. Triglycerides really need to be over 1,000. There are plenty of people kicking around with a 500 or an 800, but most of these are in the 3, 5, 8, 10,000. You know, walk in, they get xanthoma, xanthelasma, their serum is white. It's usually not subtle. I'm going to come to this in a second. This has become a major issue, this autoimmune thing. Family history, very important to do. There's a lot more familial or genetic pancreatitis around, and getting a good history of that is important. And if they have it, you know, should you be sending off their stuff, you know, and what do we send off? Well, you know, it's the cationic trypsinogen, it's CFTR, which is the cystic fibrosis transmembrane regulator gene mutation. There's this thing called SPINK. If you want to know about this, go to the University of Pittsburgh Medical Center website. Dave Whitcomb, who's a former fellow at Duke, who's the division chief now, runs an empire up there where they do this stuff. For $75, You can swipe your MasterCard and get the genetic screen done. Pretty much these days we recommend that if you're going to genetically screen somebody, that you at least send them to a genetics clinic for a counsellor to talk to them about it. So we kind of recommend that you don't in your own practices just send off the blood, because when it comes back you have some issues to deal with. I don't know how it is in Idaho, but in North Carolina a lot of people's daddies are not who they thought they were. So you get this stuff back and then they start wanting to do a little, let's check where your mum and dad was. You find the milkman was dad. And so what they do is when they go to the genetics clinics, I don't know what you have in Idaho, but the genetic counsellors tell them these things like, you may be sorry you had this test done because A, there's no treatment for this right now, although 5 years from now we may have a treatment for genetic pancreatitis. But you know, if we do a little family tree, we may find things out about your family that you didn't know. Can you deal with that? None of you want to deal with that between colons in your practice, right? You don't want those phone calls. You don't want the whole family sitting there saying you're a lying son of a bitch. You know, of course Aunt Mary was not the mother or whatever. So really, it's an easy thing to send off the blood work, and patients want you to do it. They come in all the time with stuff printed off the internet. But I would recommend that if you really think somebody is a genetic pancreatitis, that you find somewhere that does genetic testing, and they all have counsellors and stuff, and send them up there, and even do a deal with them, say, call them up and say, look, do you do this? We've got patients from time to time who we're going to think may have genetic pancreatitis. Can we send them to you? It's clean, it's quick, it gets them out of the way. But it's amazing how much they uncover when they start going into this. So you don't want to get in there.
Just a note on that. Randy worked down at the University of Utah does that.
Yeah, that group down there, that's one of their interests. This is autoimmune pancreatitis is sort of all the rage right now, and you at least ought to know about it. Like a lot of things that come out of Japan, we kind of laughed at it when it first came out. Remember when IPMT, the intrapancreatic mucin-secreting tumors, came out? This was all from Japan. Everybody said, well, this is a Japanese disease. Nobody sees this here. Well, once we went looking for it, we started finding them. There was a paper came out about 4 years ago in the New England Journal from a group in Japan where they had a series of patients, and I want to say it was probably not more than 5 or 6, who'd been through the whole workup, but they all had some kind of autoimmune thingy going on. So some of them had a Zika syndrome, dry mouth, dry eyes thing. Some of them were in the setting of PSC, and we've known for a long time you can get a sort of pancreatic inflammatory process with PSC. Some of them had autoimmune hepatitis, and they found that these patients all had an elevated IgG subclass 4, and if you did the ERCPs, they had a kind of ratty looking duct that was not dilated, but you could tell wasn't quite normal. It was kind of unhappy without being dilated, no stricture stones. And very often how they came to attention was that a CT said they had a bulky pancreas, and you've all seen CTs that said, bulky pancreas. What does that mean? Or a mass in the head. And what they did was they gave these patients steroids, and the pancreatitis all went away. So that's really the big question for a lot of us, because we didn't think we saw much of this kind of thing. And also, why would a week of steroids cure something that's a chronic immune process? Well, we now know a lot more about it, and we know that only 1/3 of patients who have autoimmune pancreatitis have elevated IgG4. So if that's what you're using as your screen alone, you'll miss 2/3 of them. We know that just a week of steroids doesn't fix them. They have to go on some chronic immunosuppression, either with steroids or other immunosuppressants. But the reason you have to know about this is if you don't know about it and you send the patient for surgery and stuff and you just get a bunch of fibrosis out, the patient may have a legitimate reason for saying, well, maybe I didn't need the surgery. And this came home to me actually about 6 months after this paper came out in the New England Journal. We had this lady who'd come to us before all this came up, who was needless to say, she was a nurse. They're all nurses, or medically associated. This woman who did 30-pound weight loss, she was having relapsing pancreatitis. She had a big fat head of pancreas that had been FNA'd twice by EUS guys with equivocal results, which many places is a surrogate for cancer that hasn't been found. And it just quacked like a duck. I mean, it smelt of cancer. I sent her to one of my guys who does Whipples and stuff, and he said that, I can't leave this in here. She's got a big mass in the head of her pancreas. She's got weight loss. we can't prove she's got cancer, but, you know, I'm not going to sit and watch this happen. So she has a Whipple, and it comes back, you know, it's just chronic inflammatory stuff. But she's happy. Unfortunately, she already was kind of pre-diabetic, so this brought on diabetes. But, you know, we get nice letters from her, and thank you very much. Sure. A year later, I get this thing in the mail that's addressed to not just me, but the Chancellor of Health Affairs and the local newspaper and the chair of the North Carolina Medical Board, and you name it, saying that this other surgeon and I were grossly negligent and should be disbarred and, you know, have our genitals removed or something like that. Strike that from the videotape. But she had been at the golf club. This lady had kind of spiraled down because in the course of all this she'd got divorced, and, you know, she hadn't been able to go back to her job, and she'd get into financial stuff. So she'd gotten this kind of personal death spiral. So she was in a bad place, but she'd been at the golf club, and she lived somewhere up in Virginia, and some retired surgeon was talking to about all this stuff and was interested enough in her case or in her or something to ask to get the records from Duke on this. And somewhere in among the path form, the pathologist had found one thing that looked like a rheumatoid nodule. He called it, looked a bit like a rheumatoid nodule. And this woman had no other rheumatic-y things going on. But based on this, he said to her, that, you know, it's, you know, the old thing from the World War II, like idle talk costs lives. Well, you know, idle medical talk causes malpractice. This said, you know, those bozos at Duke, this retired surgeon said, those bozos at Duke missed this, you know, because I just saw this paper last week in the New England Journal. You have autoimmune pancreatitis, and they didn't need to take your pancreas out. So I don't know if any of you have ever had dealings with your own state medical board, but if somebody sends them a letter like that, they're obliged to investigate it. And it's like the Spanish Inquisition. You're not represented there. You're allowed to send in a letter to say, this is my side of the story. But they don't invite you to the hearing or anything. And so, unfortunately, the surgeon I was working with blew it off completely and said, I'm not going to bother with this. And I said, well, I think you'd better bother with it. But it took me a lot of time and talking to risk management. It's quite clear she didn't have any real case. But she'd sent this to everybody. I even got a call from this reporter from the local newspaper who said after he got to the 5th page of single-space typing that was getting more and more crazy, he realized she was nuts. And you know, so the state medical board reviews it, and like 6 months later I got a 2-liner that says, we have reviewed this and found there is no evidence for, you know, malpractice. Thank you for your cooperation. I had to go and talk to this woman's house, you know, for putting me through it. But, you know, if you don't know about this and you don't think about it and you have somebody who has it, you could get yourself sued if you send them to a surgeon who does an operation for something. So you need to know about autoimmune sclerosing pancreatitis.
Question?
Yeah.
You said the IgG4 will still miss 50%. What do you look
More than
for?
50% it's...
What do you look for otherwise?
If you want to read about this, there was a review probably 3 or 4 months ago in the Red Journal, Amj Gastro, from a Korean group where they looked at all this. But you kind of put it, you take a selection of things. First of all, you get your heightened awareness of it. You ask them about this stuff. I tend to, as part of my workup on idiopathic pancreatitis, do a SED rate. You know, it comes back 100. You might go looking a little harder for some of these things. But if they have rheumatic-y things, I'll do the IgG4 if it's elevated, and that pushes you a little further towards it. They'll still get their CT or their MRI scan. They'll still get their, you know, the imaging you would normally do. And then at the end of the day, we sit down, decide, is it worth giving this person a course of steroids? And we've done this to some patients with about 50-50 benefit or not. We've tried to engage our rheumatologists in this, and they don't really believe in this. They say they don't, considering how much rheumatologic disease they see, they don't see very much of this. But I think just, I made that point just because some people, what they did was, as soon as this article came out, all patients coming through would get an IgG4. If it was negative, you were done. And that's not the case now. That doesn't guarantee they don't have autoimmune pancreatitis. So you would think that the treatment of hypercalcemia and hypertriglyceridemia would stop attacks. I find these patients very difficult to manage because none of them take medicines. They're all slobs. I shouldn't say all, but many of them don't give a damn about their hyperlipidemia. And maybe if I had to do what they had to do and take the medicines they have to do and be in the diet they're meant to be on, I'd be the same, but some of them just don't care. And, you know, if they're coming back routinely with their triglycerides at 3,000, you know, we had patients that we've tried to get in to do plasmapheresis to drop their lipids and stuff, but, you know, if they're not helping themselves, the people that do plasmapheresis are not too interested in being the sole resource. So many of these patients continue to have a stuttering, relapsing pancreatitis that will eventually lead to chronic pancreatitis. So we don't know what the answer is with steroids and autoimmune. It's still being looked at. Nobody has individually enough patients to do it. You know how you tell the sex of a chromosome, Steve?
Yeah.
You take its genes down. Okay, da-da! But the genetic stuff, just to finish, is interesting. This is the cationic trypsinogen gene with the site of the abnormality there. You would have been able to tell me that about that. Whose family is this?
Sopranos. Jimmy.
Jimmy. Which Jimmy?
Right in the middle.
That Jimmy. Which Jimmy is that?
Jimmy C.
Jimmy Carter. Jimmy Carter. Four first-degree family members have died of pancreatic cancer, right? Now, his brother may have died because he was a heavy drinking kind of guy, but there's not much doubt that he has a cancer gene in there, and we're very interested in these people because familial pancreatitis, you know, presents earlier, often starts in the teens, early 20s. They're often diabetic by the time they're 25 or 30. They usually have calcification early. They get their cancers in their 30s and 40s, not their 50s and 60s. There are people who are having prophylactic Whipple procedures, pancreatectomies based on their genetics. If you have the cationic trypsinogen abnormality, that's autosomal dominant with 80% penetrance. You have 100 times the likelihood, the odds ratio of pancreatic cancer than the ordinary guy in the street. There's some interesting associations between autoimmune, between familial pancreatitis and other diseases, one of which surprised me, and it came out of Randy Burt's work, is that people with Poitz-Jaeger, you know, the good news is your bowel polyps are not going to go cancerous, but the bad news is you've got 100 times chance the risk of pancreatic cancer. Huge risk in Poitz-Jaeger of pancreatic cancer. People who have lots of nevi, there are a bunch of the familial nevi syndromes get pancreatic cancer. There's a big association now. So the Utah group has probably been the most active in the country in looking at these and setting up registries. But I ask all my patients now who get pancreatitis, anybody in your family ever had pancreatic cancer? It's amazing how many, you know, grandma died of pancreatic cancer. And you get people that come to you scared witless because their brother died of pancreatic cancer or whatever. And so those are the people that should go and see genetic screening people and get that stuff, because there's associations with like the breast cancer gene, the BRAC stuff, the gynecologic cancers. These people, the genetics clinics go into it in far more detail than you and I ever think about. And they deserve that. But,
has the gene for the Carter family been worked out, you know?
well, if they have, they're not telling anybody. I suspect that's a HIPAA violation if I tell you, and then I'd have to kill you. So.
He's a public figure.
Yeah, I'm not sure. Yeah, I think probably his medical information is still covered under HIPAA, even though he's a public figure. They fired somebody at Duke for going into Coach K's medical record on the electronic record. He was in having this, and this is public record. He had both hips replaced recently, and there were all sorts of warnings went around on our in-hospital computer database about accessing. You know, and they track who accesses and stuff, and they said they would fire anybody who was in looking at any VIP stuff. So they had a whole bunch of people they caught looking at stuff, but somebody was in looking at Coach K's stuff, they just fired them on the spot. So. But you know, the quality of imaging now is so good. We're picking up cancers earlier. This isn't an early one. I just show this because I think it's a beautiful image. This is a pancreatic cancer here, and this is the duct that's obstructing. Just amazing the quality you can get now. And this is proteomics. I don't know what proteomics are, but it's pretty fancy when you see it. You know, proteomics is a study of how proteins talk to genes and vice versa. And there's a lot of interest in this now. There's a number of markers now that you can find that are very strongly associated with cancer, particularly this CCAM one. And this is work from Michelle Anderson up in the University of Michigan. And so when they do biopsies and things now, which the ultrasound people can do of funny looking pancreases, they can do CCAM staining. and it's very strongly correlated with cancer. So we're trying to find these things earlier. So where are we at now? You know, we're really at the very bottom of that barrel, and you're sitting in your clinic talking to this patient who's, well, you know, Dr. Schutz, you know, I've been to see everybody, I've done everything, you know, I'm still having these attacks. You know, we all do the no alcohol, low fat. You can't put people on a no fat diet. There's still people out there telling patients you've got to be on a no fat diet. And fat's what gives food its taste. So if you put them on a no fat diet, they're eating dust at the bottom of a bird cage. Nobody likes that. So let them eat a little. Just tell them, you know, don't go to McDonald's and stuff. What about pancreatic enzymes? You know, I think if they haven't been on it, it's worth a whirl. Some people benefit from it. The thing I have a terrible problem with is this stuff that came out of Gainesville years ago about, you know, huge doses of pancreatic enzymes as a way to control pancreatic pain. That's been meta-analyzed, and a bunch of studies on that show it's not true. At least, let's say politely, nobody can duplicate that data. And it's, you know, I don't find it helpful to have people on, you know, 43 on a day or whatever, but people still do it. I couldn't take that many TAC tablets anyway. But just to put them on 3 capsules with a meal and 1 or 2 with a snack is not such a hard thing to do. And if you get 1 or 2 patients that seem to get better with it, why argue with that? This is one that spins around a little bit, antioxidant therapy. It goes with some of the voodoo that Steve was talking about, but there's a lady researcher in Manchester in England called Braganza who's written about 90% of the world literature in this, and they're big believers that the evil humors of antioxidants are what cause pancreatitis, and they give people big doses of antioxidants, particularly selenium, vitamin C and E, a couple other things. And they've done work particularly in Africa and places where IRBs are not so fussy about what they do, and claim that if you give people antioxidants it helps. I've tried this in some patients, mainly as an act of desperation, and I had 2 patients that I was convinced that it made a difference to. One was a young guy who I think probably has a genetic pancreatitis, who decided not to get the genetic testing done, but put him on a little cocktail of stuff, and he took it, and then he kind of got fed up taking it about 6 months later and immediately started having attacks again, started back, stopped. You have to be careful with the vitamin E now because of the literature about cardiac risk. If you're over 400 units a day, you're at increased risk of myocardial infarction. But if any of you are interested in this stuff, there is some literature out there on how to do it. I think it's a fairly harmless thing to do otherwise. People ask me about giving sandostatin. I found it rarely effective, really pretty unhelpful. It's associated with some nasty discomfort at the injection site. Patients get pain when it's a subcutaneous injection, usually over the deltoid. It's painful and they flush. I had a patient that got sent to me who really had terrible relapsing pancreatitis and came to me actually asking if I would put her on this stuff, and she got some response to just regular sandostatin. So, you know, there's a depot injection you can get that's once a month. So she went to go on that, and I told her that, you know, she might get some side effects, and I phoned her up after a month or so and said, how are you doing? She said, well, you know, yeah, I'm doing better, I'm not getting my attacks so much, but man, that medicine's kind of rough stuff, you know, I couldn't even stand up for a day or 2 after getting it. I felt so ill, and, you know, and I said, well, let's not give you that again. No, I want to persevere. So she kept doing this, getting these shots, and then I got a call one day from an inspector for the North Carolina Pharmacy Board. It turned out that they had dispensed some multi-dose vial to her and not realized they were giving her like 1,000 times the dose. And because every time she got this thing, she got hugely hypertensive. That's why she couldn't stand up. And I got this little guy with a buzz cut who was a former detective from the Raleigh Police Force who now was the sort of Gestapo for the pharmacy board. And he barged into my clinic one day. You know, I want to wait between patients. No, I'm busy. I have to see you right now. I had to stop there. And he had my prescription, which thank God was written correctly, you know, pasted on a board, and he had to take all the details. And I said, well, you know, what happens? So all the pharmacists will have his license pulled. And, you know, it turned out that this woman actually had a history of suing pharmacies. Apparently that's a hobby of people who like to shake down the system. Apparently if you have a complaint against your CVS or something, they'll often settle it so it doesn't go to court. So he'll give you 10 or 20,000 if you get a wrong dosage dispensed or something. And she had a history of doing this, except in this case she probably had a case. But man, they were tough. I thought the medical board was tough to deal with. They were an ugly bunch. So I don't tend to, just as an experiment, put people on somatostatin or whatever. It's expensive. The insurers will often deny it. Actigol, ursodeoxycholic might reduce attacks if microthiasis is the cause, but I find a lot of patients get diarrhea with Actigol, and it costs about $2,500 for a year's supply, and it's only as good as the next dose you take. The minute you stop taking it, your biochemistry goes back to where it was, so I don't really use it in this setting. This is my Loch Ness Monster slide. People have asked me what gallbladder sludge looks like, and gallbladder sludge is like the Loch Ness Monster, much talked about but rarely actually caught in the act. And this is a gallbladder, and it's not seen exactly on its side or flat, but you can see a difference here. And this sort of grainy stuff is the sludge, and this is the bile on top of it. And we all do this. If you don't eat for 24 hours, you'll probably supersaturate and have a little in there. But that's what gallbladder sludge looks like. So patients, we all have, at least in pancreatic clinics, we all have these patients who, have a chronic problem that nobody can get the answer to. And one of my surgical colleagues at Duke, Ted Pappas, used to say somewhat cynically, give cancer a chance. And if you wait long enough, some of these idiopathic pancreatitis patients will pop up a pancreatic cancer, because all of the adenocarcinomas in the pancreas start off in the ducts. They're all from ductal epithelium. And so the idea is you get these little ductal nodules, which they call Pannin lesions, that grow into things that are big enough to obstruct the ducts, often even just side branches. And I've followed a bunch of old ladies who eventually have developed a mass that's clearly a malignancy, and some people are advocating that these patients should get annual EUS. Bill Brugge's doing that now, and actually has done some nice stuff in patients who have refused to go for surgery for these Pannin lesions he's seen and have followed them to actual cancer. So I tell my fellows that if you get these patients, they may have cancer, and you can't just cut them off and say, well, you get chronic pancreatitis, there's nothing more you can do. You have to keep an eye on them. There are a few patients who have this who are young enough that they still have good islet function, and then the question comes up is, if you really can't fix this problem, should you take the pancreas out, harvest their islets, give them back to them? At least they're not going to become diabetic, and let them deal with the exocrine issues of not having a pancreas. There are a few places around that will do that. You go to University of Minnesota, swipe your MasterCard for $100,000, they'll harvest your pancreas, isolate your islets and reinfuse them into you. And if you've got enough islets, that works very well. So you want to get these people before they'll get chronic pancreatitis and destroyed a lot of islet tissue. And they do pretty well. They don't get diabetic, and they seem to be able to manage their diabetes. They seem to be able to manage their steatorrhea and stuff pretty well. I always like to think of these, this is just a nice picture of a pancreatic islet surrounded by these, but I like to think of these as little medieval forts, because no matter what war is raging out here, these things are amazingly resistant. We're all born with about 1 million islets, and you don't become diabetic until you get down to about 200,000 functioning islets. So the clue in chronic pancreatitis is to get them before they get to the stage where it's not worth doing anything with them. And in general, we sit and wait and watch these people develop chronic pancreatitis, whereas we should take them